pulmonary emergencies in ICU.
Bismillah ar-Rahman ar-Rahim. Thanks, Chairperson, for introducing me, and it is a great pleasure for me to participate in this prestigious meeting, and thanks for Professor Sharif Mukhtar for inviting me. Thanks for Professor Alia, my colleague Professor Khalid, for inviting me to this talk. My talk today is about pulmonary emergency, and I think the term is not accurate. It should be chest emergency, so as to include the plural inside the emergencies, not only pulmonary. This is the logo of my Faculty of Medicine, Cairo University. And this is the corridor of my hospital, South Manual and North Manual. Very great distance, the longest corridor worldwide. And sometimes we think to make patinage so as to cut the distance short between 2 points. This also the new teaching Qasr al-Aini teaching hospital, or the French hospital. And this is the map of our Cairo University hospitals. The number of beds is about 5,600 beds. Now, what about pulmonary emergency? What do you mean by pulmonary emergency? I mean that pulmonary emergency, it is a life-threatening condition that require immediate attention and to avoid delay in treatment. This patient mostly present with severe dyspnea, and other symptoms and signs may include collapse or chest pain or hemoptysis. So, it is very important to make differential diagnosis in each patient presenting with dyspnea. And this topic will be of great interest for many persons, as pulmonologists, emergency room physician, intensivists, general internists, and as anesthesiologists and respiratory therapists, and resident and ER nurses, and may be involved in acute care of these patients. Okay. The differential diagnosis of pulmonary emergency presenting with dyspnea may be very broad, starting from the outside, pneumothorax, hemothorax, and into the pulmonary vascular, massive pulmonary embolism or high-risk pulmonary embolism, or acute exacerbation interstitial lung disease, or severe community or hospital-acquired pneumonia, and sometimes upper airway obstruction or lower airway obstruction, severe asthmatic attack, or acute hypercapnic respiratory failure. All of these are considered as chest emergencies. So, while you are dealing with your patient, you have to know 2 rules. The first rule is don't make it worse. And the rule number 2, never to forget rule number 1. So if you can't do good for the patient, don't do harm. This is the most important item. Regarding pneumothorax, I mean here tension pneumothorax, not the open one. The open one allows the air to get in and get out with breathing, but in tension pneumothorax, the air progressively accumulates in the pleural space, making lung to collapse and pushing the mediastinum to the opposite side. So the patient will present with acute dyspnea and right ventricular failure and cyanosis and shock. And you have to intervene immediately, otherwise you are going to lose your patient. This is very common in motor car accident or in any patient with mechanical ventilation who develop pneumothorax, or sometimes during procedures such as bronchoscopy, and this is called iatrogenic traumatic pneumothorax. Sometimes if the pneumothorax is developed spontaneously, but it is massive in amount, you should deal as a tension 1. Tension pneumothorax means that circulatory collapse, and you have to insert intercostal tube. And before of that, you can confirm this with bedside ultrasound with normal lung sliding, you can exclude the presence of pneumothorax, and the absence of lung sliding, this is a good sign for the presence of pneumothorax, also the presence of seizure sign. So, if you have a pneumothorax, you have to exclude the presence of surgical emphysema, you have to exclude other comorbidities, such as fracture rib or hemothorax, and the management will be introduction of intercostal tube. Also, the patient may present with surgical emphysema, and this is the fibers of the pectoralis major due to the presence of air under the skin. So you have to insert immediately the intercostal tube under water C, and you have to leave a stay suture so as to, when to remove the intercostal tube, you are going to take this horizontal mattress suture, leave ends long and crawl round, drain so it can be readily accessed to close the wound once the drain is removed. This is the first emergency. The second emergency is hemothorax, and what I mean by hemothorax is accumulation of the blood in the pleural space. And we have to differentiate hemothorax from bloody effusion or hemorrhagic effusion by measuring the hematocrit and taking a good history. So if the hematocrit is exceeding more than 0.5 of that of the peripheral blood, this is hemothorax. And the hemothorax means that you have to insert the intercostal tube, and if the rate of drainage is exceeding about 1.5 liters in the first 24 hours, or if the drain 200 milliliter each 2 to 3 hours, you have to open your patient either by VATS or anterolateral thoracotomy. The second medical emergency, rather than the pleural disease, is massive pulmonary embolism. Do you agree with this term? No. The new term is high-risk pulmonary embolism. Massive pulmonary embolism, submassive pulmonary embolism, old misnomers. High-risk pulmonary embolism means that you are dealing with a patient with one of three things: cardiac arrest, obstructive shock, persistent hypotension, with or without end organ hypoperfusion. So, the ESC, European Society of Cardiology, were defining high-risk pulmonary embolism as low persistent hypotension. But in ESC 2019, they corrected the term of high-risk pulmonary embolism into any patient presenting with cardiac arrest or obstructive shock with end organ hypoperfusion or persistent hypotension as high-risk pulmonary embolism, and you have to intervene immediately by transthoracic echo. If you perform transthoracic echo, you find right ventricular strain. This is pulmonary embolism until proved otherwise, and you have to arrange for CT pulmonary angiography. And if the right ventricle is not under the strain, you have to exclude the presence of pulmonary embolism and search for other causes of arrest or shock. CT pulmonary angiography will demonstrate filling defect, especially the saddle-shaped embolus, which is responsible for high-risk embolization. Before you start your treatment, you have to categorize your patient if he is intermediate high risk. If the hemodynamic instability is absent, but still the patient has right ventricular strain or elevated cardiac troponin level, one or both, you are going to consider this patient as intermediate high, and you are going to deal with him as a high-risk pulmonary embolism. High-risk pulmonary embolism, you have to start your treatment with thrombolytic therapy, provided there is no contraindication for bleeding. Or you may consider catheter-directed therapy, and it is FDA approved nowadays, or you have to consider surgical embolectomy. This paper is very nice regarding the management of high-risk pulmonary embolism in the intensive care, which mainly recommend to start systemic thrombolysis, and then if the patient has cardiac arrest, you may consider surgical embolectomy or catheter-directed therapy. When time is critical, When time is critical, you have to deal and you have to intervene very early. Do you know, by the way, this girl? This girl is Mrs. Greenwich, the lady who sold the time. She was sold the time in Greenwich with Ross Belleville, Greenwich time lady. She inherited a unique business from her father and the grandfather, taking a chronometer to clients across London who paid to view it and set their own timepiece. Time was money for Ross Belleville. Time is an issue. You have to deal in pulmonary embolism with thrombolytic therapy, whether it is streptokinase or urokinase or tissue plasminogen activator. And this is a very nice CTPA before and after, total resolution of the pulmonary circulation after initiation of thrombolytic therapy, provided the causes of bleeding was excluded, such as recent myocardial infarction or recent cerebrovascular stroke. If the patient has contraindication for thrombolytic therapy, which is called reperfusion therapy, primary reperfusion, you may consider pulmonary embolectomy. And the pulmonary embolectomy in such a patient carries a great risk. This is a video which demonstrates opening over the pulmonary artery, taking the blood into cardio bypass machine, and taking the big saddle massive thrombus. Then deflating the balloon, and then allowing reperfusion to get the air out from the pulmonary artery. And if the patient has contraindication for surgery or the bad general condition or the anesthesiologist refused to anesthetize the patient, you may consider thrombo-aspiration or mechanical thrombectomy or in situ fibrinolytic therapy. And this is FDA approved. And now we have a PERT team, pulmonary embolism response team in our hospital, which is a team responsible to take the decision and to follow these new guidelines regarding massive pulmonary embolism or high-risk pulmonary embolism. And this is a picture for catheter thrombo-aspiration and massive pulmonary embolism, demonstrating the good perfusion after removal or aspiration of such a thrombus using such a device, angiovac device. And this is a picture of the thrombus after removal. Also, through the catheter, you can deliver a low-dose fibrinolysis so as to achieve the therapeutic effect with minimal side effects of bleeding. If failed, you may consider ECMO at the end of your decision. Clot-in-transit is a term which describes the presence of a thrombus in the right ventricle or in foramen ovale, which may dislodge at any time and make a high-risk patient. You have to deal with clot-in-transit as massive pulmonary embolism or high-risk pulmonary embolism. So, this is the second medical emergency regarding pulmonary vascular disease. The third medical emergency constitutes the alveolo-capillary unit, HARF, hypoxemic acute respiratory failure, whether due to cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. If you are dealing with a patient with cardiogenic pulmonary edema, you have to consider non-invasive ventilation or CPAP or high-flow nasal cannula as primary management after correction of the medical condition. You can diagnose by the presence of bat wing appearance, and here it is very important to share that the periphery is not included by the pulmonary edema due to the peripheral pump of ventilation. So it is not diffuse pulmonary edema, it is not non-cardiogenic, it is not ARDS. The donkey analogy is very nice analogy. Ventricular dysfunction limits patient ability to perform the routine activities. This is the heart. In order to improve the performance of the heart, first you have to limit the donkey speed, thus saving energy. This can be achieved by beta blocker and procorolan. The second one is to reduce the number of sacs on the wagon, diuretic and ACE. The third is to give the donkey a carrot. This is the effect of digoxin. Last but not least is CPAP, which is batinage, which is the improvement of the cardiac performance by application of positive pressure ventilation. Looks like CPAP. And CPAP for the first time and last time to improve a patient who is hypoxemic respiratory failure due to cardiogenic pulmonary edema. So, if the patient is without CPAP, he is generating marked negative inspiratory pressure to deliver the breath. After application of CPAP, you are improving the trigger of the patient. Also, the presence of CPAP will make a redistribution of the water content from the intra-alveolar to interstitial. Also, it will improve the functional residual capacity. So, the recommendation after medical improvement, after medical treatment, you have to consider CPAP, you have to consider high flow nasal cannula, you have to consider non-invasive positive pressure ventilation. In contrast to cardiogenic pulmonary edema, the non-cardiogenic pulmonary edema is the main line of treatment is ventilatory support. Ventilatory support with a green or strong recommendation as bronch position and low tidal volume ventilation and limiting the plateau pressure not to exceed 30 centimeter water. This is high recommendation. But while application of the PEEP is responsible for hemodynamic instability, you have to precise whether you are going to open the lung or to close the lung and open your eye. As Professor Fernando mentioned, that the application of PEEP should be individualized and it should be guided by stress index or by electrical impedance tomography or by sonar or by application of intrapleural catheter. Bronch position is very famous nowadays, especially after COVID, and it is called awake bronch position. Also, this paper has certain recommendation regarding improvement in the outcome. Low tidal volume ventilation, it is green. Bronch position, green. Conservative fluid management, green recommendation. Strong recommendation. Likely make benefit, individualized PEEP, glucocorticoids, and veno-venous ECMO. May improve oxygenation, neuromuscular blockade, which is recommended in late cases in ARDS and should be introduced very early, not a rescue medication. And also inhaled vasodilator. And the last one, which may improve outcome, is the driving pressure to be limited below 15 centimeter water and also to limit the mechanical power. Regarding severe pneumonia, severe CAP is the most life-threatening form of CAP, characterized by high morbidity and mortality, and is defined by the presence of respiratory failure necessitating mechanical ventilation or hypovolemia, septic shock needing vasopressor, with the minor criteria regarding respiratory rate or multilobar infiltrates. You have to deal with high-risk patient by beta-lactam plus macrolide or beta-lactam plus quinolone. And the recommendation guidelines in 2019 in favor with beta-lactam plus macrolide. Then you have to consider high flow nasal cannula to improve oxygenation or non-invasive ventilation until the patient recovers from the hypoxemic failure. Regarding massive hemoptysis, many causes of massive hemoptysis are responsible, such as cavitary tuberculosis or fungal cavitary lesion or tight mitral stenosis or arteriovenous malformation or bronchiectasis. The investigation of a choice is bronchoscopy. The investigation of a choice is rigid bronchoscopy, not fiber optic bronchoscopy. Because fiber optic bronchoscopy, any small clot will obscure the camera and you are not going to see anything. So you have to use rigid bronchoscopy under general anesthesia, which allow better visualization, and you may use it as tamponading to stop the bleeding, then to investigate what is the cause of the bleeding. The last issue is the airway. Airway obstructions mean acute severe asthma or acute exacerbation chronic obstructive pulmonary disease. And you are responsible to improve this airway obstruction by two mechanisms, either by endocrinal control or nervous control. Nervous control means sympathomimetic or parasympatholytic. Endocrinal control means corticosteroid, whether it is systemic or by inhalation. Taking a consideration into the central airway has cholinergic distribution, while the peripheral airway has adrenergic distribution. So the administration of ipratropium bromide is important as salbutamol. Regarding acute hypercapnic respiratory failure, whether due to emphysema or bronchitis, pathophysiologic mechanisms which decrease the capacity of the respiratory muscle and increase the respiratory load, you have to start with oxygen therapy. Judged oxygen therapy, then high flow nasal cannula if failed, and you have to consider non-invasive ventilation, which is the gold standard in management of acute hypercapnic respiratory failure, and if failed, you have to consider ECMO. While you are treating your patient, you are maintaining oxygen saturation between 88 to 92, not more than that. And the studies demonstrate that the patient who achieve good oxygen saturation 97 is increased mortality. The risk of death was reduced by 78% of use of titrated oxygen. And if your patient is improving, don't withdraw the oxygen suddenly so as to avoid abrupt, potential fatal rebound hypoxemia. While administering oxygen, be careful that oxygen should be titrated because of oxygen-induced hypoventilation, because this patient is breathing with hypoxic drive, because he is insensitive to hypercapnia, and also if you give a high amount of oxygen, you are going to block the carbon dioxide transport. An effect is called Haldane effect, no available carriage for carbon dioxide, and also what's called nitrogen atelexis. If you give a high amount of oxygen, you are going to displace nitrogen, which is a potentially inert gas responsible for alveolar stability. If you withdraw this gas, which is nitrogen, you will cause what's called absorption atelexis or nitrogen atelexis. So in IV is the gold standard. Prevent the development of failure, prevent the invasive ventilation, therapeutic alternative to invasive mechanical ventilation. Start with non-invasive and follow and observe your patient. If the pH is markedly acidotic, this is not contraindication for non-invasive ventilation, but you have to be ready, steady for intubation. if the patient has disturbed conscious level or marked severe acidosis with disturbed conscious level, consider invasive mechanical ventilation, and it is not a battle between invasive and non-invasive. So the use of non-invasive ventilation shouldn't be used in patient with imminent arrest or severe respiratory acidosis or disturbed conscious level or persistent acidosis. The last item is acute severe asthma, and I think all of us is aware about the management of acute severe asthma. But what is important, what is the pathophysiology of acute severe asthma? The acute severe asthma, the patient has a chronic inflammation, and on top of that, there is acute edema, acute airway obstruction, which will cause the patient to suffocate if you are not going to interfere immediately. The mortality was increased in patients with mild asthmatics because of overusage of short-acting beta-agonists, the blue inhaler, salbutamol, because you are correcting airway bronchoconstriction, leaving the airway inflammation ongoing. Excessive beta-agonist use is associated with asthmatisis, and this demonstrates that you are correcting bronchoconstriction, leaving the red airway inflammation ongoing. So it is forbidden nowadays to use short-acting beta-agonist as a rescue medication. You have to use with the beta-2 agonist each time anti-inflammatory, because each airway bronchoconstriction is associated with airway inflammation. And this is the GINA guidelines, which describe if you use more than 3 inhalers per year, this increases the risk of asthma exacerbation. And if you increase the amount of inhaler up to 12 inhaler per year, this will increase the asthma disease. How to identify your asthmatic patient? Any patient who deteriorates on systemic steroid, or any patient with history of intubation, or any patient with history of admission, or any patient with history of frequent emergency room visits, this is called high-risk patient. If this patient is improving on short-acting beta-agonist in front of you, don't let him to go to home. You have to admit and observe. Clinical features of asthma: tachypnea, tachycardia, working accessory muscle, systolic arterial paradox, silent chest, central cyanosis, refusal to light supine, mental confusion. Acute severe asthma, you have to control inflammation by steroids, and you have to maximize beta-2 agonist, ipratropium, magnesium sulfate, and thiophyllin. And we have to mention that we have a conventional measures and unconventional measures. Beta agonist and ipratropium are conventional, but magnesium sulfate unconventional, methylxanthine unconventional, general anesthesia unconventional. Invasive mechanical ventilation is the only key if your patient is going to deteriorate and the risk of arrest. NIV has a gray, debatable issue. You have to make a differential diagnosis in each patient with wheezy chest, whether it is lower airway obstruction such as COPD or bronchiolitis obliteranis or cystic fibrosis or bronchiectasis, obstruction such as tracheal or main stem tumor or foreign body or vocal cord dysfunction, or if the patient has cardiovascular disease as pulmonary edema or congestive heart failure or bronchopneumonia or herpetic tracheobronchitis or carcinoid or cocaine inhalation or Churg-Strauss syndrome. Beta-2 agonist you have to give. It's better by nebulization or MDI by nebulization because of the hand-lung relationship, breath and breathe. You have to improve compliance. Nebulization is more important. If you consider to give budesonide by injection, you are going to give systemic steroid, and if you are going to give by inhalation, is it better to give single bolus dose or to give multiple small repeated doses? The recommendation is toward multiple, small, repeated doses. In summary, one last question. What is the best treatment for acute asthma attack? The best treatment for acute asthma attack is a few days before its occurrence. Thank you. شكرا جزيلا.